Welcome everyone to the Structural Heart Disease Live Case Session 1 on TAVR. So my name is Alan Young. My co-moderator is Dr. Myung-Ki Hong from Korea. And also our panelists is James Flaherty, Dr. Simon Lam, and also Agate. So we look forward to have two cases, and after that we will have a 10 to 15 minutes of discussion, really sort of dive in deeper into these two cases. So I'm going to turn it over to Myung-Ki to introduce our first case.
Okay, thank you for the introduction, Dr. Young. Okay, in the TCTAP, in every year, they show us the very interesting and educational cases. This is the structural heart live session for the TAVR procedure. This session have two TAVR cases from the Asan Medical Center. The first moderator is the Cerebral, and the second case is TAVR. Okay, first case is Cerebral. Can you hear me?
Yes. How are you?
Good morning.
All right. Good morning,
Professor
everyone. All right. So welcome you all to our another live sessions from the Asan Medical Center. I really, thank you for Dr. Hong, Dr. Alan Young, and our distinguished panelists for our live cases. Alan, how are you?
Good. How are you?
All right. It's maybe late night. Night in.
Not too bad. 6 o'clock.
6 o'clock. It's great. However, anyway, it's really thank you for your active joining. All right. So we have two TAVR cases today. So I'd like to introduce everybody. Know that Dr. Jung Min An is just he way back from Stanford. Dr. Kim, our senior fellow, and many cooperators, and to use the usual, CAD lab.
Yeah.
And so all right. So as your first cases, Dr. Gumi will present the case history first.
Yes, thank you. She is 18 years old female. She was admitted for exertional dyspnea with NIA class 2. She had a history of end-stage renal disease, so she is on dialysis 3 times a week. The echocardiography showed very severe degenerative AS with normal average systolic function. Next. The risk factor of this patient is hypertension, and STS score is quite high. It is 10.63, belonging to high risk profile. Next. Echocardiographic findings showed every function was preserved, and peak velocity is elevated to 4.6, and mean pressure gradient is 49, and aortic valve area 0.62. Next. In coronary angiography, there are intermediate stenosis in mid-LAD, but LAD FFR showed stable value to 0.8, so we decided medical treatment in this region. Next. This is CT finding of this patient. In aortic annulus view, aortic short diameter is 18 and long diameter is 20.9. And annulus area is 296.6 and annulus perimeter is 61.5. Next. These are sinus of Varserva and ST junction. Sinus to annulus area ratio is 2.59. It is relatively larger than the mean value. And also ST junction to annulus area ratio is 2.23, also larger than the mean value. Next. There is no visible calcification in LVOT. Next. Also, we analyzed the amount of total calcium. In this patient, amount of total calcium is 114. It is relatively smaller than the mean amount of total calcium. Next. It is longitudinal analysis of calcification. Next. Coronary height is quite a little bit lower in CT. Height of RCA is 9.7 and height of RCA is 13.7. Next. Peripheral vascular diameter is large enough to transfemoral approach. Next. This is sizing table for SAPIEN 3. According to this table, we decide to perform the SAPIEN 3 20 nominal size to get 10-point area oversizing. This is patient presentation.
Oh, great. I think it's perfect. So you, Doctor, will you choose the SAPIEN?
Yeah, SAPIEN 3.
Expandable.
Yeah.
Right. So we're gonna choose the 20. So would you explain what will you do for particular these cases? Actually, I think it's almost 80. However, in average, STS score is quite lower in Asian people, Asian patients, and I saw actually the Asian patient has a relatively lower incidence of a comorbidity, etc. However, particularly this case is really higher, it's more than 10 STS scores, relatively high risk, and however, very technical issues is quite a low volume of calcium in a small valve. And so, would you explain the strategy for this patient? And so,
Yes, we will perform the SAPIEN 3. There is no cause for the why we select the SAPIEN 3, because in this case, a relatively low risk profile for arterial complex. So the SAPIEN 3 or the self-expandable device, we can select both the device. But in this case, we selected SAPIEN 3. The one interesting point is, I think there is two interesting points. The first is intermediate coronary, mediated coronary stenosis, FFR is 0.80. The second interesting thing for this specific patient is low the coronary height, particularly left coronary height is just 9.7.
you show the slide, the height of the coronary.
So
right, that's point. The coronary, the height is relatively short.
So the first of all, I'd like to discuss with the intermediate LAD stenosis first.
Yeah, so Zhenming, Alan here. So very interesting. What is the size of this patient, like height and weight, BSA? So, a 20 millimeter SAPIEN 3, is this going to be a mismatch at all in terms of her size?
Element of the mismatch. So,
Can you explain again? Can you?
Oh, sorry.
Patient body weight and height.
Height and weight. So, because I don't, maybe you showed that already, but is there an issue of prosthetic patient mismatch using a smaller valve?
Would you show first slide? First slide.
Yes, it could be possible because the Asian population, the artificial animals is relatively smaller than Western population, so it could be the higher incidence of patient prosthesis mismatch. But actually, so far we didn't know that the clinical relevance of PPM. Some studies show that the PPM is associated with the long-term mortality, but many other studies also show that the PPM is not associated with the long-term mortality. So, regarding the patient age and comorbidity, the relieving the AS is more important than the PPM itself.
We have the three panelists, James Flaherty from the Northwestern United States, and Dr. Lam, Hong Kong, and Dr. Tay from Singapore. Okay, any comment or question? Actually, this case is very interesting and clinically important, particularly in the Asia, in the small airway size of the patient, female patient. Actually, we have a lot of the discussion point as Dr. Young commented. Actually, I agree with the size of selection of the SAPIEN 3 for the maybe
인덱스가 없네.
access for the future coronary intervention, but the size of the patient is small, so there is some possibility of the PPM, and when you use the SAPIEN 3, will you do the protection of the coronary artery during the TAVR procedure?
Sorry.
Coronary protection
Right.
during the TAVR procedure. Actually, the height of the coronary from the analysis that the rep coronary system is a 9.7. It's a relatively lower, shorter. So there is some chance of the occlusion of the left main. So your strategy is without the coronary protection or with some coronary protection.
James, Flores, how are you?
Hey guys, Jay.
Mm.
I think this is a good choice. It's an 8-year-old dialysis. So we're really looking for symptomatic relief. I think, I don't remember the measures, but I think the sinuses are generous enough, even though the left is relatively low, that there's a low risk of coronary obstruction with the SAPIEN 320 in this case.
Mm-hmm. Actually, Alan mentioned about the mismatch concerns. However, the patient is
30
very small,
30 kilogram.
30 kilograms, very small lady. So, and 20 millimeter SAPIEN is not small, particularly this patient, right? And another point is PPN concern. Recent data analysis, anyway, just TAVR years and not exactly stable years and not too much, predictors anymore. So for the clinical relevance, and so as you noted, the recent study, low risk patients are actually more effective stent areas, group of TAVRs rather than the SAVR, and so maybe PPM concern, especially the Asian, patients, I don't know, however, we do not too much concern about that. And the second issue is you mentioned about the height is at 9.7, relatively low ones. However, you don't need, actually you didn't prepare any coronary, preparation, etc. And so would you explain that one, the reason why?
Yeah, because there are two factors for the risk of coronary obstruction. The most important thing is coronary height. Coronary height is low, higher risk of coronary obstruction. The second important consideration is sinus valsalva size. This patient sinus valsalva is almost 32, 29. So there is sufficient room for coronary perfusion even after the balloon implantation, stent implantation. Another consideration, could you show us the calcification? So the location of calcification, left coronary sinus calcification is very low. So I think this patient, although the height is low, the risk of coronary obstruction would be very low.
All right. So anyway, the total calcium is 114. And next slide. A very interesting point. And next, next. And so we want to see the ratio, coronary sinus ratio. All right. So we have our own kind of a CT algorithms, pre-evaluation of a TAVR patients. Look at this, sinus annulus ratio average, mean sinus ratio is 1.87 something. However, this is a very big sinus compared with the annulus size. And so the important thing is location of calcium, amount of calcium, very small, left coronary cuspis, relatively small calcium, and very big sinus rather than compared with annulus. And so we don't too much concern about the coronary obstructions, and so we don't need any unnecessary preparation for that. And so we have some confidence, have some experience about that. And so, all right. So last one. Would you do the direct, stent or the pre-balloon dilation for this?
Yeah, we prefer the direct without pre-balloon valvuloplasty if the calcification is very low. This patient, the calcification volume is 100. Our mean volume of our patient is 356. So this patient, the calcification is very low, so we prefer the direct valve implantation.
Do you have any criteria in case of for the pre-balloon inflations?
We have arbitrary criteria based on our median calcification volume. Median calcification volume is around the 400. So less than 400, we prefer the direct valve implantation. The more than 400, we prefer the balloon valvuloplasty before valve implantation.
All right. I think that's a very important point. Is before the procedures, I would say is we have our own CT, algorithm to predict the clinical outcomes. So, Lam and Dr. Tay, Dr. Lam, would you some comment for us?
Good morning, Professor Park. I'm Simon.
Right.
Nice to see you. So I agree. I will do direct implantation of most of the sapien valve. The only scenario, maybe we have a sizing issue. Maybe the coronary height is really a concern. I think the sinus here is very big, so I don't think obstruction is something that I really worry. But in case I have some very borderline challenging case, I will do a balloon to test the valve relationship to the coronary ostium when it is fully opened. But this is controversial. But this is some kind of treating me psychologically in case I have borderline cases. I would do that. And for 20 millimeter valve, I think it's a good choice, but I will make sure it would optimize the expanded, leaving no ways. And sometimes I may do a little bit oversized and very carefully check the gradient afterwards. And I think would be fine for this patient, especially in the future, we may need to coronary access to treat the LAD lesion.
Yes, so I think Simon is a good point that, I think I was going to ask, what are your sort of deciding algorithm between the sapien and here, an Evolute, for example? What would be your sort of thinking, choosing one or the other in a small annulus patient?
Right. And the last one, Dr. An, actually, I'm not sure. So you didn't, you decide you don't want to do the, cry osteo protection. So I don't have any responsibility. All right. Anyway, last one, 20, you decide the area of size 10%, right? So this is very small amount of calcium. And so what do you explain that the criteria in some, based on our data, there's an area of size in case of very small calcium amount, what would you do?
We can do the more than 10% oversizing. So 10 to 15% oversizing would be safe in case of very low calcification.
Right.
So, yeah.
So we're going to start with the 10% oversizing, and then after you made it at 8 grams, after that 8 grams, you're going to decide 0.5 cc or 1 cc over. Anyway, very low calcium cases, 15 to sometimes 20% area of size is quite, safe. All right. So we want to start. Okay.
And I think Dr. An also brought an interesting case about the FFR.
All right.
I thought that was an interesting thing to discuss maybe later on. But in some patients, maybe not this case, if the FFR is borderline, we do see that some cases the FFR becomes more positive after the aortic valve is implanted. So in this case, I think a good choice is choosing a small, short valve. So just in case the coronaries become positive in future, you still have access to the coronaries. So I think I agree. I think it's an excellent choice.
Immediate after FFR again, there is any that is meaningful?
Yeah, there is some controversial data because of the high elbow pressure, the FFR value before TAVR would be the value would be overestimated in some studies. So this patient data, the FFR is 0.80. So there is some risk that after TAVR, FFR could be less than 0.80. Even though regarding the patient age and comorbidity, first of all, we prefer the medical treatment for this patient. So we decided that this patient, the medical treatment. In addition, the SAPIEN 3, rather than the Evolute R, coronary access is easier than the Evolute system. So SAPIEN, it would be another reason why we selected SAPIEN 3.
Actually, you prefer second, right?
Yes.
rather than self-expanding flow valve. So would you explain that as well? Actually, difference is based on the data. So okay, you have to explain that one. How would you do that?
Okay, the leaf and then pull the valve.
Pull the system back,
Yeah.
and then
What wire do you use, Jinmin?
fix the
Yeah. Excuse me.
So what kind of wire do you have in the LV?
yes.
Yes. Wire is LV. Yeah.
What kind? Sorry, what kind?
Safari wire. Small
Sorry.
safari
So-
wire.
All right. Short one.
Yeah.
All right. In terms of a procedure wise, it's not difficult much, and keep the maximum angles on the system just before they enter into the device of the orifice. Would you show that one? Okay.
Dr.
I
Bob,
think it's almost
before they introduce the SubCam 3, please show us the hemodynamics for the audience.
perfect. The pressure is perfect. All right. So we have already.
Could you show us hemodynamics?
Mhm.
Systole is 115, diastole is 31.
Okay.
Okay, I just put the device in, and then the doctor arms would you pull the push back up to what do you think? Up to second point markers and short markers. Okay, test please.
Test.
Make it a little bit lower, so to pull in the wire and the push back a little bit for the device itself. All right, this pigtail. Would you take your contrast, please? It's too high. What do you think? Test again.
Test.
All right, I want a little bit.
Yeah.
All right, I want looking for the coaxial status a little bit further. Test, please. All right, a little bit. It's fine.
Yeah.
Test again. I think it's a relatively small one, and so I think it's okay. Test please again. This is
In this injection, we
view
think
okay?
about the upper
Axial view.
border of the
All
valve
right, great.
is the coronary ostium,
Test.
prevent
Okay.
the coronary obstruction.
Facing and
Facing on.
full contrast. Okay. What do you think?
좋습니다.
Good.
Inflation.
Great. Great.
하나, 둘, 셋, 넷,
4,
다섯.
5. Okay. Great. All right.
Facing up.
Facing up. Pull the system out. LVY in. Serious. What do you think? Here, we want to take a. Okay. Zoom, please. One more zoom. Before that one?
Yeah.
Okay, great. So we're gonna do aortogram first, and then okay, injection. Okay, and then Dr. Kim will check transthoracic echoes a minute after the status. What do you think? Yeah.
You have a wire, obviously. That looks like where the wire is, the leak is from the wire. So, Jinmin, can you get an angle that is make the valve more coaxial?
Okay, just a moment.
Yeah, so take a look as well. Yeah.
Why not? One more aortogram here.
Mm-hmm.
It will be pulled out back. All right, great.
Good.
Okay.
The level of the implanted valve is the excellent, and the implication, meaning of this angiogram, that in some cases with the very heavy calcium and the very tightest aortic valve, and sometimes it causes the moving such kind of the calcium over valve leaflet cause the left main occlusion. However, in these cases, lesser amount of the calcium favoring the protection of the left coronary ostium. So it affords to the simple procedure in these cases. Very excellent.
All right. Thank you. Anyways, if you look at the aortic concerns, we discussed a lot about the coronary protection, etc., etc. However, look at that. Previous CT evaluations, we clearly know that the big sinus size, pretty enough space between the device, to the coronary ostium, in the left main, and the height is 9.7, relatively lower. So, however, we don't, too much, worry about that one. And if you look at the angiograms, actually, 10% oversize of the device. However, still there are, I think, is quite enough, space. If you look at the CT algorithm, long diameters, almost 21 for 21, 20.9 meter, 21 is almost there. And so, all right, Dr. Kim, what do you think? Is any?
Yeah, there is no parallel leakage, and it's okay.
When we think about the valve degeneration over the time, you see actually this patient was received the 20. It's relatively small. So what is the final aortic valve area after SAPIEN 3, and maybe 3 years later and 5 years later, and annually the valve aortic valve areas are smaller. So I have some question. Even though procedure itself is a very excellent and perfect, but the final valve area.
What do you think? Echo, I'm sorry, Dr. Ho.
괜찮습니다, 교수님.
Echo finding is good?
Yeah.
Okay. So you, all right. Immediate after, so we can do just, pressure measurement, LV and L2. And however, immediately after, before the discharge, the echocardiographic follow-up data, even after the good, pressure, changes immediately after. However, the peak velocity concern remain based on our data, 2.5 and 3 something, right? Still, there are some, moderate aortic stenosis is remain. However, continue follow-up data in some restenotic cases, without those, clinically restenotic cases, and popular as a general, the main, patient had actually is maintained the, peak velocity. So what do you think?
Yes, even though there is some residual velocity, it could be a significant ppm, but even though the clinical relevancy would be very small, so the small pressure residual pressure gradient less than 2 or less than 2 or 3, I think it is clinically not meaningful, but we need more data for this issue.
All right. Okay, so finally, so we're going to move the whole system.
Another clinical point is in patient with the poor renal function, such as this patient, the end-stage renal failure patient. Usually, the severity of the atherosclerosis and the systemic calcium was very, very severe. So in such kind of cases, aortic valve calcium is very severe, and a lot of the calcium in the coronary artery, and we have a lot of the difficulty to have the access site in the peripheral artery. However, fortunately in this patient, there is no such kind of the difficulty.
Yeah, fortunately, yes, Dr. Hong, I fully agree with Dr. Hong's mention that usually the ESRD patient have extensive aggressive coronary atherosclerosis, but fortunately for this specific patient, aortic valve calcification is very low and peripheral artery relatively good, so a very good candidate for TAVR procedure.
Right.
All right. Finally, Dr. Anju, we discuss a lot about minimal
Yeah.
approach of a TAVR procedure and 48 hours, 2 days stay on something.
Yeah.
So what do you think about that?
I think this patient just stayed one day CCU and 1 day
Mhm.
outpatient, 1 day the general ward and
Mhm.
discharge after the 2 days later from now.
For the educational purposes, could you show us the ECG
Yeah.
after the TAVR? There is no block and no change of it. Okay,
Pressure?
excellent.
Right. So,
Maybe checking the zeros of your lines.
Yeah, again. We are checking zeroing again.
Yeah. So one interesting observation, just make sure that, when patient with renal failure and dialysis, there's diastolic blood pressure may be low to start with, right? So
Yeah.
you want to make sure that you don't get alarmed when you finish and see the diastolic pressure being low. So that's why it's important to look at it beforehand and look for a change and not be alarmed with AI or anything like that.
okay. Pressure? Just, you want to show that as however, LV.
This is
I think
LV
the
pressure.
invasive gradients are also pretty important, especially in the small bowels, because like Dr. An and
All right.
Dr. S.J. Park mentioned,
What do you
sometimes they
think?
get elevated pressures afterwards, maybe due to pressure recovery in these
I
small.
think it's perfect, right?
Yeah.
Right,
Just-
agree.
All right, and then Dr. Hong mentioned about the diastolic pressure for, could you AR indexes, could you tell us some AR
Yeah.
index, just pressure monitoring?
Diastolic pressure is 60, so I think the AI index is very nice.
Mhm.
So initially, diastolic pressure is only 30, but
Yeah.
after TAVR, diastolic pressure is 51, almost 60. So definitely, this patient may have a very low risk of significant PVL.
Great,
In addition, we discussed a lot about the PPM in this patient, the small annulus, small valve implantation, but there is no pressure gradient between the LV and aorta, so I think there is no PPM. So
in fact, this is not a PPM cases, right? Small bodies
Yeah.
and the appropriate size of the device. All right, so for the.
And I think your implantation is really good in that is on a little bit on the high, so it really maximize the valve area, effective valve area as well. So
We're
that
gonna show the last aortogram.
Yeah.
And finish the procedure, right?
Yep.
Okay, what is it? And okay. It's okay?
yes.
Okay. Yes.
Ready?
For the two. All right.
Ready?
a little bit, huh?
Very trivial, right?
Yeah,
Mm.
very trivial.
Good.
Not cover the whole LV in the single part.
Ready?
I like this view. not much, regurgitations, PVL.
Yeah.
Okay.
You want to hide everything.
All right. So
Very
we're
good.
gonna move, second case. So really thank you, Alan, Dr. Hong, Lam, Tay, Flaries, long time no see, right? All right, see you.
Thank you very
Excellent.
much. Great case.
Excellent.
All right. Move to the,
Okay, TW Bob.
Okay, can you hear us?
Yes, of course, clearly.
Okay, thank you. Thank you for joining the TCTAP 2022 live case demonstration. My name is DW Park from Assam Medical Center. I'm going to introduce the team and the first assistant and Professor Do Yun Kang, and the second assistant, our TAVR specialized fellow, and Dr. Gosadi from Saudi Arabia. So, and Dr. Kang, can you present the patient, the background and history?
Yes. The patient is an 82-year-old gentleman admitted for exertion dyspnea and syncope. He had a history of hypertension and colon cancer, underwent surgery. And we checked the echo, and echo showed very severe degenerative aortic stenosis with normal LV systolic function. Next. And he has his STS score for mortality was 2.68%. Next. And his ECG showed normal sinus rhythm with narrow QRS, and echo showed very severe aortic stenosis with a peak aortic velocity 5.2 millimeter per second, and peak and mean transaortic pressure gradient of the 106 and 69 millimeter mercury. And next. And we checked the other things, and we thought that the cause of dyspnea would be the aortic stenosis, and we checked the CT for TAVR procedure. The annulus area was 467 square millimeter, and the annulus short and long diameter was 22.8 and 27.5. Next. And we also checked the size of the sinus of valsalva, and the area, sinus area to annulus area ratio was more than 2. And ST junction size was largely enough. Next. Also, there was no severe calcification on the LVOT, and the size of LVOT was similar to annulus area. Next. And this is the view of the calcium volume of the house-built unit more than 450. And total amount of the calcium is more than 1,000 cubic millimeter. That means the large and heavily calcified valve. Next. And also there is some severe calcification of the aorta and iliac arteries. Next. And the height of the coronary artery was higher enough, more than 13 millimeter. Next. And there is some stenosis of the iliofemoral arteries, but it was large enough for the SAPIEN, the valve system. Next. And this is the sizing chart of the SAPIEN 3 valve. When we implant the 26 millimeter, there will be some 11% area oversizing. Next. And this is the CT-based annulus coplanar projection. Next. And this is our planning for TAVI. The SAPIEN 3 with a 26 millimeter valve, and we will first try with the 2cc underfill because of the high amount of the calcification. With the 2cc underfill, we will just perform the 5% oversize with the initial device. And first we plan the left femoral access side, but after some echo sonar evaluation, we approach it to right femoral artery. And we will perform the predilation because of the high amount of calcification, and also we will perform we are trying to coronary protect device because of the high amount of calcification. Next.
Okay, could you show us the calcium, the status? So, and okay, next one. Okay, looking at the calcium complexity is very high. It's a 1,000. The scale is very big, and so we're gonna show this patient prepare the sentinel protection, cerebral protection device, and this patient would be good candidate for sentinel protection device, and on the basis of the calcium amount. At this moment, we will have some discussion point for this patient.
Sure. When there's this amount of calcium, it's always a concern, because I think, a lot of analysis look at bicuspid, look at tricuspid, but I think the most important factor is really the amount of calcium, whether it's annulus, the valve leaflets associated, various different type of complications. So whenever there's heavy calcium, we pay a certain amount of respect to the valve and its complex. So here, I think, given the high gradient as well, that I think a predilatation will be very helpful to make sure that your valve can cross and not having issue with that. I think sentinel is also good when you predilatation with calcium coming off. I think that would be also a good choice to cerebral protect. Exactly what size, I think we can take a look once you deploy, and then whether you can add a CC or something like that to enhance the expansion if necessary. But this is another case that's something that sometimes if it's high enough risk, would you consider having transesophageal monitoring, for example, to look at it more carefully, whether and when you deploy the valve, whether there's any leak or whether there's any perforation. But that's optional, I would say.
So, and in our country, I don't know the current status of the Sentinel device used in the daily TAVR the practice in our country. And just a couple of months ago, initially launched it, and we are available some few cases. We are experiencing some few cases. So I know the recently and the protected TAVR trial in the Cerebral PI and targeting the absolutely all comer TAVR patient. I know the included completed 30,000 patients, and this year we are available the prognostic and the clinical impact of a routine the cerebral protection device in the daily TAVR practice. And how the status in your country and James and the Edgar Tay and I know the Simon and you are experienced also the cerebral protection device. So which patient usually used for Sentinel device? Is there any some clinical indication for use of the Sentinel protection device? In terms of cost is also expensive. We consider. I guess, and you do not routinely use the Sentinel protection device. What the patient criteria is eligible candidate in your daily TAVR practice?
Hello, Duckwo, it's James.
Yeah.
Pleasure to be back here, at least virtually. So there's a great debate about when to use Sentinel in the US. Alan pointed out some obvious patient features, heavy calcium bicuspid. But sometimes strokes, embolic strokes occur without any of the telltale signs. So some centers try to use Sentinel in almost all cases if it's anatomically appropriate. But I don't know of a specific algorithm to guide its use otherwise. So I think it's up to individual operators at centers on whether to use it routinely or to try to select out when they would use it based on some of the features that were discussed earlier.
I guess in Singapore it's fairly similar. We don't really have an algorithm, but certainly with the available data, we have been discussing these with patients. So with every patient, we give them the option of having this done because there is potential risk. And like James said, you can't really predict well which patients are going to have a stroke. And so the main cost here will be borne by the patient because it's not covered by the healthcare. So, but we do tell the patients the pros and cons of such a device, and then if they would want it, then we would implant it. But the ones that we tend to favor, obviously, the ones with pre-dilatation, bicuspids, valve-in-valves. These are the typical ones that we sometimes choose or favor.
So for this patient, usually we ever know, and we should check the initial brachiocephalic artery and the left common carotid artery status, and we check this is a conventional left 30-degree view, and we can see there is some anatomy of the right the brachiocephalic artery, left common carotid artery usually, and right common carotid artery looks like some dilated. The upper limit of the criteria less than 15 millimeter would be okay. Yeah. This patient, we measured the 14 millimeter. 14. Yeah. So, and we compare the right radial artery. This is a 6th branch, and use the wire, guide wire. We use the Xion wire in the device recommendation. Grand Slam 150 or 300. I think choice fit is okay, and we are the experience and this wire. Okay, Xion blue is good. So I'm gonna little bit the insert, and then over here, and this is a 16 branch. Okay, wire 조금 더 풀 넣고. The area 13이죠. Okay, so make sure the pedicle cast over here. 더 들어갈게요. 오케이, 루프 보인다, 그지? 자, 조금 더 내려와야 되겠다, 그지? 피그텔을 조금 뒤로 뺄게요, 요거. 오케이.
I think your pigtail is hooked on it.
오케이. 좀 피그텔. 오케이. 잠깐만, 됐어. 이렇게. 요 뒤로 좀 풀백하고. 오케이, 리를 풀백. 자, 밑으로 다시. 오케이, great. and then you should be careful over here.
네, 거기입니다.
Okay, you mark over here, and then usually the proximal band 요 정도. Okay.
네, 지금 괜찮습니다.
Usually and the 10-15 millimeter from the arch, and here is we are trying to release and the first 1번. Okay, this is the proximal loop over here, and then you can make sure. Okay, good. Pullback 됐고. Okay, then here we make the band and the second. And then, okay, and then over here, let's slightly pull back. 잠깐만, 이거 살짝만 풀어볼게요. Slightly pull back. Over here, make a band more. Okay. This is the Xion blue.
티그테일을 조금 더 밑으로 내려야 될 것 같습니다.
아래쪽으로. 더 아래쪽으로. 오케이. 된 것 같아, 그지?
네, 예.
Okay. To make sure. Over here.
이번은
나도 봐. Slightly the whole system slightly pull back. You make sure over here. Okay, you feel slight resistance over here, and then here with the deploy the filter of the distal. Then you can make sure over here. 위에 보여주고. Okay. Okay, good. This is 조금 더 이렇게 됐다 그지? This is whole set, and then to make sure again, and then slightly pull back over here. You can resistance. Okay, good. And this is the all set for central protection device, and the all procedure is very intuitive and not difficult. And if you're gonna do and the 2 or 3 time experience, you can do. Okay, here I'm gonna do the TAVR procedure over here. 자, 요거 피그텔 좀 더 들어갈게 이제. Okay, good, great. 됐다, 이제 over here. 자. So, and I think this year we definitely available the final result and protected the TAVR trial, the 3,000 patient and primary endpoint clinically relevant cerebral vascular event. Okay. 이거지? 자, 잡아. 위에 보이시고. 됐다, 그지? 오케이. 여기 잠깐만 뒤로 조금만 더 한 거를 확실하게 플로로 위에 보여줘봐. 뒤로 확실히 당긴 거 맞지? 됐다 그지? 오케이 됐지. 자 접어주세요. Okay, this is Teflon wire.
So DW, just want to make sure that your this catheter is not through that the sentinel loop. Is it okay through that? I mean, it's probably okay, but it's just still.
Okay, we make sure again.
Yeah.
Okay, 요거를 새로 푼다.
Point it down first.
Okay, got it. We make sure again. This is the wire. Sometimes we be careful the kinking.
Yeah.
잠깐만, 이걸 한번 빼볼게. 더. 오케이. 됐어. 자, 밀어봐. 오케이, 잠깐만.
A1으로 좀 들어가서.
Maybe pull the sentinel back
오케이,
a bit.
됐다. Good.
That's
Great.
great.
Wonderful.
Okay.
자, 잡아. 들어갈게. 자, 줘보세요. The Vmax is 6.5, mean gradient nearly 70. It will take some time, the wiring.
Show you the baseline image.
Can you show us the baseline image? 튜브 좀 낮추고. Okay, over here. 렌즈 C로 완전히 넘겨놓고 링터 코드 한번 준비해 보세요. Okay.
What is your favorite wire for crossing the valve here?
Yeah, this is a routine, the tapered wire, and the soft wire, it doesn't work. If it doesn't work, we will change the more strong ring top wire. 더 strong wire.
This is straight ring top
ring
wire.
top wire. 한번 저기 한 백그라운드 디폴트 올려봐 주세요. And our routine usually use the AL1 if it doesn't work, and we're gonna change AL2 and sometimes JR. Great. Okay. 자, 딱 해놨지? 자, 들어간다. Here. 바로 하고 pre-dilation 바로 할게요. And we're gonna do pre-dilation two sides down 20.
Yeah.
20
millimeter balloon.
Okay. 네, 위에 한번 보여줘. 루프 지나갈 때 한번 보여줘. 그렇지. 오케이. 오케이, 굿. 이렇게 놓고 피그테일 줘봐. 피그테일 포지션 잡고 하자. 자, 보면서 빼자. 자, 보면서 we're gonna put the pigtail and make sure the band, supply wire band properly. Okay.
Is that not a pre-shaped wire? How often do you use a pre-shaped wire?
This is safari wire.
Safari,
Yeah.
small.
Yeah, safari. Yeah, small. Pre-shaped wire. And most case, nearly 100 case. Sometimes we use the strong wire, like round cast for. Okay, 잠깐만, 조금 더 넣지. Okay, good. 자, 보면서 빼자. And the round cast wire, some tortuous ultra, some and the very complex case, and but most case we're gonna use the pre-shaped safari, the small loop or normal loop. Okay, I'm gonna do pre-dilation. Okay, 딱 잡았죠? 자, 테스트. 자, okay. 자, 패싱 on. We're gonna test first. Okay, great. Okay, 자, 준비됐죠?
Pacing is good.
Pacing is good. 자, 밸브 스탠바이 하시고요.
This is 20
자, 위에
millimeter.
보여줘. 위에.
Yeah.
루프. You make sure. 어디야? 들어갔나? 아직 안 들어갔지?
Yeah, loop. In the arch.
In the arch. 잠깐만 잡고 있어. 저기가 아까부터 걸렸어. 내가 루프를 새로 만들어. 오케이, 굿. 잡아. 오케이. 됐죠? 센터. 차분하게. 자, 페이싱 온. 오케이, 인플릿. 푸시. 오케이. 디플릿. 오케이, 페이싱 오프. 오케이. 자, 위에 보여주고, 위에 보이죠? 루프. 1, 2, 3, 1, 2, 3, 1, 2, 3. 자, 이거 보면서 빼자. 자, 강 선생님 보면서 빠지면 안 돼. 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Okay. And then we're gonna do direct 26, 2cc on the pair. Is targeting nearly 3% oversizing. Okay. Kosadi come here. And our TAVR expert fellow and the Dr. Kosadi, okay, push. 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Okay, slightly. Push here. Okay.
좋습니다, 선생님.
자, 보면서 와이어 안 빠지게 조심하고. Okay. Okay. Pull back. Go back at the white marker. Okay, good. Okay, great. Okay, there's a release. Okay.
So one step.
Okay, just one more step. Okay, get release. Then over here. Okay. Then slightly more. 조금 더. Okay. More. Okay, got it. Okay. And then keep the wire. 위에 보여주고. Slightly bend. Okay. Keep the wire. 잠깐만. 이게 피그테일 요거지? Okay. Okay, we can make sure. 잠깐만, 요 와이어를 됐다. 그지? 오케이. 자, 됐어 이제. 코플 하나 뷰?
지금
코플 하나 뷰? 네. 피그테일 물 인서트. 오케이, 들어간다. 와이어 킵하고. 오케이, more easily passed wire. Okay, slightly pull back the sheath marker. Okay, 네, 잡을게. 자, 테스트 온. 오케이, 위치 괜찮다. 좀 더. 자, 테스트. 이 코플라너 뷰지?
네.
오케이. 이것들 뺄게.
네.
자, 준비됐지? Everybody stand by.
네.
오케이, pacing on. 오케이, contrast. 오케이, inflate. 1, 2, 3, 4, 5. Deflate. Okay, pacing off. Okay. I think it expanded well. Upper part. Okay. Okay, good. Okay, we're gonna check the transthoracic echo. Okay, good. And the more than 95 case, we do the MAC procedure, and just a very high risk valve in valve, and the very high risk case, we do general anesthesia. Okay, Dr. Kang, can you show us the? Okay, good.
Very nice.
This is the long axis of the transthoracic echo, and there's no evidence of the severe regurgitation. And now let's see the short axis. Okay. View is not so good, but I can see the valve. And there's some very small amount of the paravalvular leakage, as you can see, very small jet, not significant.
Okay,
Let's
we're gonna
see.
check the angio. 자,
Okay.
여기 한번 플라나비 맞추고 천천히. 손 한번 잠깐만. 한번 일단 얼른 한번 찍어볼게.
And there's no pericardial effusion or
Okay, good.
other severe.
살짝 뺄게. 살짝. 오케이. 자, 준비됐죠? 오케이, 갑니다. 자, pressure. So I think there is no PVR, and then we're gonna remove and then make sure the pressure gradient is okay. 1 to 3, 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 1 to 3. 자, 피그텔. And then we will check it up the hemodynamics.
Okay, in echo.
So far, I think the procedure is the old procedure is very elegant, excellent, and particularly I was impressed with the Centennial device procedure. I want to also want to see that the removal of the
Yeah,
Centennial
okay,
device
got it.
and check the amount of the
Okay, absolutely.
the
Yeah.
emboli, the
Okay.
amount of it after the TAVR procedure in
Okay,
real time.
okay. We're gonna show us. So, and still, I think the panel and discussant in the same thought about the routine use Sentinel device. The price is not cheap. As we are in our nation, 80% should be paid by patient, and the $30,000 paid by patient. Addition, if you're gonna use the Sentinel device, we should add nearly $3,000. Okay, good. So, and the price is not cheap, and So, okay, 다 됐죠? Okay.
I think that's why, even in the US, when we have a blanket system, is still, to Medicare, a lot of the patients, but still
하고
the cost is not covered.
찍고 remove sentinel
Yeah.
보자.
고생하셨습니다, 선생님.
Okay, okay, 좀 됐죠?
And you're
Okay,
ready.
this is the final view. Okay. Shot. Okay, absolutely no PVR area view. 네, here. 입니다. Okay. Okay, good. Okay, we 보여주잖아요. Sentinel remove. We show the step by step the removing of the sentinel. Okay. This is the same procedure, and then the overhaul step. And the first, 손 보여주고 있죠? And the remove, and the 3. This is number 3. And then pull back over here, pull back, and deeply. 됐죠? And then slightly push
밀면서 네, 돌리시면
D1. This is D loop over here. And then this is this is a different angle. 일로 돌리면 되죠?
반대쪽으로 반대쪽으로.
반시계 이렇게.
counterclockwise rotation.
오케이. 여기서가 들도네. 잠깐만. 풀리고 있나?
네.
이쪽으로 완전히.
예.
조금 더 밀어볼게. 오케이. 자, 여기서 조금 더 풀어야지. 반대쪽으로. 자, 이게 좀 덜 풀렸어. 오케이. over here. Then. 됐죠?
If the amount of the calcium or some tissue in the within a centennial devices, the live cases
여기
is
이렇게.
I suppose that it is the real shocking.
됐다.
Okay, I
조금 더.
really wanna see how much amount the tissue was extracted.
됐다. 이 정도. 오케이, good. 됐어. 오케이, 오케이. We're here. We're here. And then 조금 뺄게. 됐어. Y 좀 넣고. Okay, okay, good. Here is the one. Okay, this is retrieve gently. 끝까지. 잠깐만. Okay, while you're
I think there is some, there's still some not pushed to the very end yet,
Yeah.
so that's why there's a
Okay.
trap. Yeah.
Yeah,
Okay,
from
got it.
angle.
Okay.
됐어. 자, 이제 여기서 한번 빼볼게. 천천히 홀 시스템, pull back. Okay, good. 여기서 이렇게 홀 시스템. 자, 쭉 떼볼게. And then we make sure how much amount that. 잠깐만. 위에 보여주고. 오케이, good. 그럼 여기서 보여주세요. 끊어서. Okay, we're gonna show us. 카메라가 이쪽으로 구주. 필터를. 여기다 대고. 오케이. Okay. Will shows the amount of filter. Okay. 다 됐죠? 그러고 나서. 오케이.
But in our experience, I think it's difficult
Yeah,
to predict what sorts of scenario will give rise to a lot of embolization, because sometimes we have very straightforward case, very minimal in manipulation, but eventually got something on the basket.
Yeah, it really is unpredictable, and also sometimes you just get little foamy material and not a lot of particles. So I've not seen one that is really a lot of pieces yet. So it's very hard to define what is friable, not friable, and so that's why it's hard to have clinical criteria. It's either you do it in all patients, or you just pick some clinical criteria that you think is higher risk in embolization, and so obviously the big trial will tell us a bit more.
Okay.
Prevent trial.
This is looks like a gold mining.
Please show it.
Yeah.
And we
Okay,
need some
okay.
special
Yeah.
technique.
Okay, we
wanna
are
see
now.
it.
Yeah, we are now something doing gold mining.
It's very difficult to expose the filter and get things out. I think the system may be better to improve in the future for that.
Okay. Shall I? Okay.
We remove the filter and wash it.
The
Filter.
our gold mining specialist is now doing.
그 조그마한 데브리즈가 있거든요.
그걸 뒤에다가 뭘로 보여주나 그걸? 잠깐만.
There is a small white debris.
오케이. Could you show us the camera? 뒤에다가 흰색으로 하면 안 보일 거야. 파란색 저걸 대고. 안 보여? 저 불도 좀 비춰주고. 흰색으로 하면 안 보여.
Can you see in the camera? There was some white debris.
이거 한번 대봐. 한번 대. 불 켜면 더 안 보여?
화이트 밸런스 때문에.
그래?
I can't see it. It's a very tiny amount, is it?
Very glary.
Yeah.
Please,
한번 보여드려봐, 선생님.
how impressive it is.
지금 앵글이 어떠세요? 잠깐만. 좀 보여, 강 선생?
네.
약간 있어?
Yeah, there's a small white debris, a size of the 0.5 millimeter.
Okay, so
Okay.
I think if we are accumulated experience and we found the more bigger gold. Okay, thank you. I think that we are experienced and the 4 and 5 sentinel device. The overall procedure is very intuitive, not difficult. And then this year we will know about the final result protected TAVR trial. At the time we will know what is the best criteria for the sentinel protection device. I think this live case demonstration would be very helpful to understand how do function the sentinel device, how to manipulate the cerebral protection device, and this is our final result.
Yes.
Okay. Any comment
Excellent,
or
good
question?
job. Excellent, good job, TW.
Okay.
Thank you.
We will upload the debris photo.
Okay. After final mining, we will upload the debris photo.
Yes, you can weigh it in milligrams, whatever. Okay, thank you.
Thank you.
Thank you.
Bye-bye. Thank you.
Bye-bye.
Thank you. Bye-bye.
Thank you.
Analysts.